lakh women die every year. One woman dies every 7 minutes from cervical cancer. WHO has given us a target of 90, 70, 90. And in this, the 70 stands for a 70% screening or coverage of women throughout the country. And therefore, all of us need to have a knowledge of cervical cancer screening. What are the latest guidelines? Which is the age group to start? What are the best ways of screening? And what are the various latest developments in this modality? And today we have none other than Dr. Leela, who will be talking, who is the president of the Indian Colposcopy Society and who's also conducting various colposcopic trainings for the diagnosis of cervical cancer. So we have a very big personality who will be just upgrading us about cervical cancer screening. And then we are lucky to have none other than Dr. Sudha Sharma, Vice President, Indian Menopause Society, a great academician, and we are really lucky that she has given us a consent to be here in this program today. And then this another great personality we have with us today is Dr. Lakshmi Ratna, again a great colpologist. She has many firsts to her honor, and she has really worked for in IMS and Hyderabad Society also a lot. And at present, she has been Joint Secretary of Indian Menopause Society in 21-22. So I welcome you all. And now I welcome Dr. Anju Soni. Dr. Anju Soni is the convener of this CCC series. It is her vision that she would like to start a series where we covered the infectious diseases first, and now we are on to oncology, and then we would like to touch up on various other topics in this series. So thank you, Dr. Anju Soni, for having such a great vision of, and that too, the vision of calling all special academicians who would be talking on different topics. So Dr. Anju Soni, as you know, is President Indian Menopause Society, and she has been she's member ICOG. She has been elected as Vice President Foxy for 2026, and she has a lot many laurels to her to herself. She has been Secretary General of IMS, Governing Council member of ICOG, and she was awarded the Best Committee Award for the HIV and AIDS Committee of Foxy. She has many publications to her honor. So I would now request Dr. Anju Soni to kindly give us her vision and her a few words of wisdom.
Thank you, Shubha, for your kind introduction. It's really overwhelming when you talk of this series, which has been work of the whole team who has been working day and night to conceive the idea. And it's my pleasure to welcome all of you today for this 32nd episode of Triple C Wisdom Series, Confusion, Clarity, and Consensus, focusing on one of the most critical areas of women's health, the cervical cancer screening guidelines. And this masterclass will be taken by none other than Dr. Leela. We all know that cervical cancer remains one of the most prevalent cancers, and the timely screening is essential for early detection and also effective treatment. And this session aims to provide a comprehensive overview of the latest screening guidelines, equipping all of us with the knowledge and best practices to implement in our day-to-day practice. And today, when we explore on what and when and why cervical cancer screening, and what are the current methods, and when to screen the patients based on age and the risk factors, and why keeping up with the latest guidelines can make a significant difference for the patient out care we are going to give. Our goal is to ensure that by the end of this masterclass, you will feel empowered with skills, knowledge, and to confidently apply these guidelines and enhance your approach to cervical cancer prevention. So, without further ado, let's dive into this crucial topic and begin our journey towards better patient care and outcome. Thank you for being here. Let's all get started. Over to the chairperson, Dr. Sudha and
Thank you.
Dr. Lakshmi Ratna, who have been themselves a great academicians. I'm sure all of us together will definitely reach a lot of uh, level of knowledge. And with me is in my team is Dr. Anjana Chauhan, who is herself a gynae oncosurgeon, Dr. Shubha Sethia, and Dr. Priyanka. And they have been working day and night to conceive the whole concept. Thank you very much.
Thank you,
Thank
Dr. Anjuswamy. And now I welcome Dr. Sudha. She doesn't need any introduction. Ma'am is an icon, we can say pillar of IMS. And ma'am, welcome. Not going in detail of your CV because it's a very long thing. And we will start the session straight away. Welcome, ma'am.
Thank you, Dr. Anjana, for such lovely
And
words.
Dr. Lakshmi also, she's also been one of the pillars of IMS. And I always seen she is having a very beautiful, these all ladies are wearing very beautiful sari, ornaments, and it makes the IMS very lively. So I invite both of the chairpersons to chair the session and take the session forward.
Thank you, Dr. Anjana, for such kind words. Nice introduction. Thank you, Dr. Shubha, and great Dr. Anju. I always congratulate Dr. Anju, thinking out of the box. Dr. Shubha, Dr. Anjana, Dr. Priyanka, and the whole team, for this webinar under CCC web series. What a lovely, appropriate name you have chosen for this. And wonderful, this is 32nd series. It is great to know that. And congratulations for choosing such an important topic for discussion. I tell you, the more we read about it, the more we learn, we see, the less it is. Because we know that 25% of all the global deaths due to CA cervix occur in India. And I think Dr. Leela will, enlighten us more about the statistics. But what is the basic reason? Lack of effective screening and access to timely treatment. And we have, very able faculty with us, and Dr. Lakshmi wanted to do the honors of introducing Dr. Leela. So Dr. Lakshmi, over to you.
Thank you.
You wanted to do this.
At the outset, I must thank your entire Jaipur team. The hard work behind starting such kind of sessions is not a joke. And Dr. Anju Soni, such a vibrant, jubilant, and beautiful, most beautiful. Ever since I have seen her, 2013, Dr. Anju in Cancun, Mexico. First we have seen, ever since I think Dr. Anju is becoming younger and beautiful. Welcome you, madam. Greetings from Hyderabad. And Dr. Sudha, such sweet and very much stabilized, and with her sweet smile, with all her charm and glamour. Greetings from Hyderabad. And Shubha, of course, my Jaipur friend. Thank you very much for giving me this opportunity to chair this session of our own friend, Dr. Leela Digmati. And she is such a simple but very dedicated and committed person in her work. I knew her for several years. We got close ever since in the IMS travel only, though we was living in the same city. But I realized her potency, her efficiency, through Meta also and her chapters also she has written. So Dr. Leela is a gynecological oncologist. She was very much interested in oncology. She was, to begin with, was a gynecologist only. Now she has become a gynecological oncologist. And she's worked a lot of, I think, many years in St. Teresa's Hospital, Hyderabad. And she's the president of Indian Society of Colposcopy and Cervical Pathology till 2024. Certified colposcopy trainer and master trainer for colposcopy workshops, invited faculty for several organizations, including World Congress of IFCPC, Colombia, and she has started her colposcopy training and one-stop cervical screening clinic at Vizag, and member of several committees, and a DNB teacher and examiner over a decade, and organizing secretary for ISCCP 2019 National Conference in Vizag. And since 2014, She was with several NGOs, creating awareness, vaccination, screening for cervical cancer with regular camps in the North Andhra. Started the program of screen the mother and vaccinate the child for cervical cancer elimination, because we know that 27% of the new cases in the world are from India. 27% of deaths from cervical cancer are from India. Though I think very much is there for us to actually bring it down to the people who are unreachable. We have to reach them. And like Leela, we have to, I think, spread the awareness and encourage all the young girls to have this vaccination. So there will be a time where we'll be free from this cervical cancer. I hope so. With this, I welcome Dr. Leela to start her lecture. Thank you.
Yeah, thank you very much, Dr. Lakshmi Ratna, for an elaborate introduction. So it's really wonderful to be part of this CCC program again. Thank you very much, the entire team who is working so hard for this CCC webinars. And by default, I have become part of the CCC because I went to Jaipur first time when the Foxy conference was there. And then again, a few weeks ago, Dr. Anju Soni called me for organizing a panel discussion. And this is the third time. So I should consider myself, and probably all of you have to consider that I'm also a part of the CCC. And once again, I'm also not CCC part, I'm also part of IMS in addition to my colposcopy workshop. So I was so fascinated by the work done by many members of IMS, and I mean, because now I have reached an age where I'm seeing more of a perimenopausal and menopausal women. So I definitely take the history of all these menopausal symptoms and try to counsel them about these menopausal changes and other things. So it's wonderful to be again being invited for this webinar. So without much delay, I'll start my lecture. So let me share my presentation. Yes, I just wanted to make full screen. Yeah, so the topic that is given to me is on cervical cancer screening methods. So as the faculty have already said, I thought, I know most of you must be doing it and most of you are aware of what I'm going to present, but it is just a brief recap of what we have been doing and what we have learned over the years. So basically, I'm touching upon various cervical cancer screening methods with the latest guidelines and just a few slides towards the end, what to be done if somebody is screen positive. So if you look at this map, you will understand what is the burden of cervical cancer in various parts of the world. So the lighter the color, the incidence is less. As we move towards Asia and Africa, the color is becoming darker and darker. That means we have more number of cases per 100,000 women. So wherever the cases are less, like in Australia, the color is so light. But when it comes to our own country, still we are in the darker range. So we have a big responsibility on all of us as gynecologists or whatever specialty we are doing to work towards reducing this cervical cancer related morbidity and mortality. Not only reducing the morbidity, mortality, as such, we need to reduce the number of cases being diagnosed every year. So when it comes to exactly our own country, the figures, it is the second most common cancer. We all know, the first being the breast cancer. And again, in India, majority of women get married at a very young age and they are susceptible to these HPV infections. So that's why we do see many young women being diagnosed with cervical cancer. So the age range is between 30 and 59 years. And the reason is we don't screen everybody like what the Western countries do. So by the time we start screening, most of them must have already had a pre-cancer, or maybe for that matter, majority present to us when they have symptoms related to cancer. So when it comes to Globocon 2020 statistics, every year we are seeing almost 123,000 new women being diagnosed with cervical cancer. The tragedy is, as I said earlier, majority we would be seeing in stage 2B and beyond. It's very less common to see women in very early stages of cancer, cervical cancer, where we can operate. So by the time we see, they would be 2B or beyond that. So as a result, even if you diagnose and treat them in that stage, we are losing them because of their failure to respond to the treatment or the treatment related morbidities and mortalities. So when it comes to age standardized rate, it is 18 per 100,000. And the tragedy of the cervical cancer is, even in our own country, India, the incidence varies from region to region. The Northeast still has got a very high incidence of cervical cancer compared to other parts of our country. Actually, in Telangana and Andhra, the incidence is quoted from the population cancer registries is about 9 per 100,000. So the WHO says we need to reach a target of less than 4 per 100,000, then only it is considered to be a public health problem. So we still have a long way to reach that goal. So when it comes to all stages together, the 5-year survival of women being diagnosed with cervical cancer is only 46%. That means we are losing almost 54% of women within 5 years of diagnosis of cervical cancer. That means we are losing many women in their prime age of life. That means the age where the children are growing up, or where they're supposed to, the children get married or enjoying life with grandchildren. So they are losing all those enjoyments in their life. So, and the tragedy is, again, it is a preventable cancer. It's not that we can't prevent it. So it's a cancer which has to be prevented, but we are still struggling to reach the goals of preventing the cervical cancer, especially in the developing and underdeveloped countries. So again, we all know as gynecologists, it's not something you're not aware of. It's caused by human papilloma virus. It's a virus from DNA virus of papillomaviridae family. So we have more than 100 types of HPV, of which at least 14 are called high-risk types causing various cancers. It's not just the cervical cancer alone. It causes the lower genital tract cancers, the anus, vulva, vagina, and in men, it causes penile cancers. When it comes to oropharyngeal and anal cancers, both men and women are at risk of HPV-related cancers. So it is a sexually transmitted infection seen in about 5 to 8% of general population. So if we go by the population statistics, it appears as if the incidence of HPV is not very high. But if you look into the types of HPV, which is responsible for causing cervical cancer, we know 16 and 18 are the commonest types, which are seen in more than 70 to 80% of cervical cancers, what we see in our country. And the good thing about HPV is 80% of women clear their infection by the time they reach the age of 30 years. So the burden naturally comes down, but still those who are having persistent HPV infection, it is our duty to catch them quite early to see that they will not have the effects related to HPV virus infection, or if at all they had any cellular changes, which we need to detect early so that we can give them timely treatment and reduce the risk of the pre-cancer moving towards invasive cancer. So that is the main thing what we all need to work. So this is again a very familiar side. Most of us know how the HPV infection causes cervical cancer or the oncogenesis. So if you look at this side, this is a normal cervix. We know the cells, the basal, parabasal, intermediate, all the superficial cells. So once the sexual activity starts, both the partners, the male and the female partners, have got the risk of getting exposed to cervical infection. So these are some of the risk factors for having, exposed to HPV infections more often than the monogamous relationships, multiple partners. It's both for men and women. It's not that only women having a multiple sexual partners. Even the man having multiple partners also will be a risk factor for a woman to get the cervical cancer. Early sexual debut, we know that, high parity, And male circumcision is supposed to be quite protective against this HPV infection occurring in women. So that is what we know about the, but it doesn't mean that we need to recommend circumcision to everybody. So once this HPV infection goes into the lower genital tract, we know that again 80% would clear the infection, but those 20% who don't clear and where the infection persists, so slowly the viral particles get integrated into the cellular DNA and start producing changes in the cell. So initially it would be in the transient phase where it gets cleared, like how we clear most of our viral infection. But once it becomes a productive infection, that means the virus getting integrated into the cells, it will start multiplying with the cells and produces all the cellular changes, which we are trying to detect by doing a colposcopy. Before that, whether somebody has got the infection in their lower genital tract or not, which we are going to test by our HPV testing. So susceptibility when it comes to progression, what are the factors which actually lead to progression of HPV infection in a particular woman? If somebody has got a high-risk HPV infection, we know the 14 types. And if they have a weak immune response like HIV or other immunocompromised states like those who are having leukemias, lymphomas, or those who have renal transplants and immunosuppressants, then those who have got other sexually transmitted diseases as a cofactors. And of course, this genetic susceptibility, I don't have much knowledge about this genetic susceptibility of somebody, probably those who, I mean, maybe born with low immunoglobulins in their body might be one of the reasons for this genetic susceptibility. So coming to the microenvironment, multiple HPV infections, most of us feel that we clear the infection, but there is no guarantee that we don't get reinfected with the HPV infection. And of course, smoking, long-term of use of oral contraceptives can alter the environment in the lower genital tract. So that can also change the microenvironment and then can increase the risk of progression of this HPV infection. So once the infection persists in the lower genital tract, as I said earlier, the virus gets integrated and it causes genetic instability. Then there is activation of suppression of the P53 and retinoblastoma genes, and activation of these oncogenes E6 and E7, and ultimately the cell gets converted into a precancerous one, and then finally it can progress into invasive cancer. So this is actually the steps of oncogenesis from HPV infection to development of precancer and cancer. But the good thing about the progression of the changes are, they're all take a long time to happen. So we know, like, somebody gets married at the age of 18, 20, and even if she gets infection, by the time she reaches 30, according to our statistics, more than 80% would clear. So those who have infection, if they can't clear, if it persists, it produces slowly the changes. So it takes more than 4 to 5 years for the changes to happen. And the changes also usually happen in the low grade to high grade. So we have a very long window period where we can offer screening to our women to see whether they have a high risk of this HPV infection lurking in their lower genital tract, if infection is there, whether it is in the transient phase or whether it has produced changes in the cellular cervical epithelium. So all these things can be done in that long window period. So we are actually waiting for the age of 30 years, mostly for HPV testing, because we want the infection to be cleared naturally. So this slide is very informative for most of us to know the natural progression, the timelines, and how we need to screen women from the age of 30 using the HPV test, or even before that, we can probably use the cytology, which I'm going to discuss in subsequent slides. So we are already, we are aware of this global strategy. It is stressed again and again by the team here. The vision of the world is to see the world without cervical cancer. And what is the threshold to see? We have to have less than 4 cases per 100,000 women years. Then it is no longer a public health problem. So as long as the incidence is more than that, definitely it is considered to be a public health problem. So that's why WHO has given these global targets to look towards or to work towards the elimination of cervical cancer. So we know this 90%, 70%, 90%, it has been there from the year 2020, once the global strategy is declared by the WHO. So we know that 90% of the girls to be vaccinated fully by the time they reach the age of 15 years, and 70% of women have to be screened with a high precision test at least twice in their lifetime. It's not just doing a screening, but all screen positive women have to be further evaluated, and wherever indicated, we need to give them the treatment. So then only the cycle would be complete. So if you do like this, according to our Sustainable Development Goals 2030 target of 3.4, we will see 30% reduction in mortality from cervical cancer. So these global targets, we are all very much familiar, and we are all working very hard, either at whatever level you are, whatever setup you are, we are all working hard to reach these goals. And the time is running out, that we are left with another 6 years. So if you reach these targets in the next 6 years, then we would be seeing the downfall of the incidence of cervical cancer in our country, which may take another 30, 40 years. So coming to, after knowing the burden of the cervical cancer, the global targets and everything, now what are all the tests which are available for us for doing the screening for cervical cancer? So we all know what the definition of screening is. It is testing asymptomatic and healthy population to assess the risk of getting a disease in future. So it helps in picking up disease in pre-invasive stage. So by effective treatment, we can reduce the risk of invasive cancer. So when you look into the criteria needed for screening, cervical cancer fits into that, because the cervix is easily accessible. We know the natural history, how cervical cancer happens. We can do very easily the screening tests. We have time-tested screening tests. We also know what can be done if a screen test is positive. So all these things are known to us. The only thing is we have to put our knowledge into action. So mass screening of all eligible women reduce the incidence of cervical cancer and mortality. It is proven beyond doubt in most of the Western world. So when I was working in UK in early 90s, there was so much focus on this cytology and everything, because it's almost like how you ask the age of the woman, it's a must that every woman should be asked, when did you have your last pap smear? So that used to be part of the history in UK, in history taking in UK. And with the cervical cytology alone, they could drastically reduce the incidence of invasive cancer in UK. And for that matter, now in most of the Western world, they are able to reduce the incidence of invasive cancers by call and recall method. So once a woman reaches a particular age of 25 or 30, once she's enrolled into the screening program, she will automatically gets the reminders once in 3 years or 5 years, depending upon the screening test, to come for a repeat test. So this call and recall phenomenon in the Western world, especially in European countries, has helped a lot to reduce the incidence of invasive cancer. So coming to the screening test, it is nothing new to you. You all know that visual inspection with acetic acid, that is VIA, and now we are using even visual inspection with the magnification. Then VILI, that is visual inspection with Lugol's iodine. Then automated visual evaluation using artificial intelligence, which is picking up now. And cytology is again conventional liquid based. We are very familiar with that, and most of the teaching institutions are doing this cytology quite regularly. And of course, HPV testing, which has come into place recently, but still the government policy, the Indian government policy is doing VIA as a part of public health program or in the screening. And HPV testing is picking up, especially in private sector. And in some of the government organizations, probably as a pilot studies, there are institutes which have started using HPV testing. One good thing about HPV testing is it can be a provider collected, or even a woman herself can collect and give the sample for HPV testing. So if you look into the recent guidelines of WHO, which came into existence in 2023, they have put the molecular testing as the first line, and then they have moved to the cytology, and the visual inspection is towards the end. So when it comes to the molecular testing, this is the high-risk HPV DNA testing, then DNA methylation and protein biomarkers. Most of us are doing HPV DNA using the real-time PCR tests, and conventional pap smear is still being practiced. And of course, liquid-based cytology is slowly taking over conventional. But with regards to the cytological interpretation, both stand at the same level. The thing is, in the liquid-based cytology, you don't see so much of mucus and debris. And especially with the low-grade abnormalities can be picked up easily in the liquid-based cytology. Whereas in conventional, you may miss some low-grade abnormalities, but when it comes to high-grade abnormalities, both stand the same. And then another advantage of liquid-based cytology is the same sample can be used for HPV testing. And there are also studies of using the same cytology sample for dual staining to identify P16 and Ki67, which are actually markers for HPV-induced changes. Then, of course, visual inspection, which is very popular in our country. There are studies, and especially the healthcare workers being trained to do this VIA. But the disadvantage of VIA is it is quite subjective, and you can't do VIA, especially in postmenopausal women where the transformation zone goes in. And now, as I said, there are lots of magnification devices where people try to look at the cervix after application of acetic acid under magnification, so that the interpretation may be better than just looking at the cervix with naked eye. So VIA, we know how it is to be done, why it is so popular, because it's simple, cost effective. And still, most of us feel our country is a low resource setting. But on the other hand, we say in the next decade, India is going to beat many developed countries. So I really don't know. It is whether we are a low resource setting or we are moving towards a high resource setting. But you need to have a freshly prepared acetic acid every day for the test, and you have to apply it over the cervix, and the results are to be read after a minute. And any estowide change over the transformation zone is reported as VIA positive. And the principle behind this estowide change is coagulation of nuclear proteins in the immature cells. It's highly subjective test, as I said, and it is not useful in menopausal women. And especially where nowadays, sometimes I do feel when we are doing more and more C-sections, sometimes I have a difficulty in identifying the squamocolumnar junction and the transformation zone, especially women who had repeat C-sections. That is my personal experience. So, of course, VIA still stands good in certain situations. I'm not saying that we should stop doing VIA. Actually, application of acetic acid is again a part of our colposcopic examination too. Then as an adjunct to VIA, we also do VILI. We don't do VILI in isolation. We do it as a complementary to VIA. So wherever there are estowide changes, which are immature cells, they won't take up iodine stain because they don't contain glycogen. So VIA positives, that area will not take up iodine. So then VILI also becomes positive. So this is a simple tray where if you are practicing this VIA or VILI, or even for your colposcopy also, you need to have all these chemicals, the instruments and everything ready in your gynec OPD, or if you have your colposcopy OPD or preventive oncology, wherever. This is a very simple thing which I usually keep ready. These are the three balls. One is for saline to clean the mucus. This is for acetic acid, which usually we dilute. We get the glacial acetic acid, and depending upon the volume we need, you can use, if you are going for a camp, you can take 95 ml of distilled water and 5 ml of acetic acid. If you are doing less number, I usually take 19 ml of distilled water and 1 ml of acetic acid. And this is Lugol's iodine. This also one can prepare in his or her hospital. You can ask your biochemistry people, they will prepare and give you. These are the Cusco specula. These are the swabs to clean and apply various solutions. This is the Tischler's forceps. So this is a very basic thing, and whatever equipment you need, you can actually add on according to your the services you are offering at your clinic. So this is, I mean, this actually a part of preparation. Everybody who does this VIA should train the nurse. It's not that the doctors only would be doing this dilution every day. You can train a nurse or your junior doctors how to mix it. Here we have to use the distilled water, not saline. Many people think that saline can be used, but it is the distilled water which has to be used. So now this you can buy glacial acetic acid, which is available in the market, and distilled water is also easily available. So you can mix and keep everything ready according to the number of women you are going to screen in that particular day. This is again Lugol's iodine. These are available, potassium iodide and iodine crystals in the market. We can get it, and in this proportion we can dissolve and prepare this Lugol's iodine. We need to store it in a brown bottle, amber colored bottle, and the storage is for 1 month. So you can prepare 100 ml and keep it. And once it's over, you can again prepare it. So usually I buy these crystals and I get it prepared and keep it. If it's more than a month, most of the times I prepare 100 ml like that. So it would last only for a few weeks. It won't exceed more than 4 weeks. So like that you can prepare. And so coming to the VI interpretation, so you all know that the speed of appearance of estovite change, color intensity, borders and demarcation, location, color uniformity. So these are all the guidelines. These are also given in the latest FOXY recommendations, the FOXY guidelines on cervical screening, which are modified a few months ago. So this is how it is not basically for the gynecologists, but if you are training healthcare workers to work in the fields, you need to tell them how to interpret a estovite lesion, how fast it appears, how many minutes it lasts, whether it is a thick estovite or thin estovite, where is it situated. So all these things you can actually train them. And these are some of the pictures. Actually, these are all there in the ISCCP website also. We have a lot of teaching material. You can, and these are also there in the IARC Atlas, that is Indian International Agency Against Cancer Research. So these are some of the pictures from there also. So if you know that this is endocervix, this is ectocervix, and this is the squamocolumnar junction. And this is the transformation zone, we all know. So if you see any estovite lesion in the transformation zone, usually that is significant. So here we are seeing this estovite lesion at a 12 o'clock position. So you can see the colors. This is the new squamocolumnar junction, and this is the old squamocolumnar junction, and in between is the transformation zone. So we are seeing the estovite lesion quite clearly. So we will offer the interpretation according to the type of transformation zone, the location of the estoviteness, and the thickness, thin, all these things we can interpret. That is how we use VIA for interpretation of abnormalities on the cervix. So this is actually here you are not seeing much of a change. Everything looks quite normal. So that means it is a negative. I mean, this is before application of acetic acid, and this is after application of acetic acid. So we are not seeing any estovite change in the transformation zone. So this is the green line is the old one, and this is the new one. We are not seeing, it's quite clear. So, but this columnar epithelium may take up estovite change very transiently, just for a few seconds, because these are also immature cells. And the mucus gets coagulated after application of acetic acid. So this is again another picture where you are seeing a little thicker estovite lesion here on the lower lip, and it's almost going up to, if you say from 5 o'clock to 4 o'clock to almost up to this level, it is going. So this is also the bigger the lesion, thicker the lesion, we consider that it may be more, I mean, higher grade of pre-malignant change than the lower grade. So that is how we can, it will be useful for us to think of an estovite change, and wherever needed, we can consider doing a biopsy. So here we are seeing quite a significant estrovite lesion, but the lesion is actually going into the os also. So unless we open up the external os, we really don't know the limit, how far it may be even going into the endocervical canal. So these things will help us again, not only for diagnosing, but also planning the treatment for these precancerous lesions. So that is a little bit about VIA, using VIA for screening and interpreting the VIA changes and other things. So pap smear, I really need not talk much about pap smear, which is being done quite extensively in most of the hospitals. They're more comfortable in doing pap smears than VIA. So pap smears is introduced. We know about George Papanicolaou, and very commonly educated people say pap test, pap test. So pap test is nothing but a cytology. So this I can skip, and slowly we are moving towards the liquid-based cytology. As I have said, we have thin prep and sure path preparations. So there is a slight difference in the preparation. We just collect using a brew and put it in this liquid medium and send to the lab, and they centrifuge and collect the cells, and the cells are stained. It is a semi-automatic actually. They collect the cells, stain it, and then examine under microscope. There are some advancements happening. They're using even artificial intelligence, the computer-aided programs, where instead of manual reporting, this computers can report. And of course, they are trying to correlate between the manual and automated reporting systems before actually they start using the automated things for final reporting. So these are I usually like to see the cytology slides, especially the trainees, I insist. So once you get an abnormal smear, you should go and ask the cytologist to show you, so that you will know what exactly the abnormality is. And once you see an abnormality, you should try to correlate with your colposcopy findings, with your biopsy findings, like that. So that's why going and meeting our cytologists now and then is also very good to upgrade our knowledge. Especially the normal CIN1, the LSIL and CIN1 is a little tricky even for the experienced cytologists to interpret. But once we start seeing it, we also will get some idea about these various smear abnormalities. This is a little difficult, and of course I skip these slides because you know how the Bethesda system is interpreted and what are the reports we get from our cytologists. Most important you need to see is whether what we can test from our end as clinicians is whether we are giving adequate samples or not. So we can say whether if the pathologist says yes, the sample is adequate, the sample is satisfactory for interpretation, that means as a clinician we have collected our cytology sample right. So that is very important for us. Then after that, if there is a transformation zone component is there or not, all that they will look into and give us. And they will give us the interpretation of squamous abnormalities and glandular abnormalities. So based upon the abnormalities, what they have described, we will decide further what is to be done to our patient if a pap smear comes positive. If it is negative, usually we call them back after 3 years for a repeat testing. And of course, now the in thing is HPV testing. So many HPV tests are in the market. But when you choose a HPV test, you need to know whether it is a validated HPV test or not. So this is the list given in our FOXY about various HPV tests which are validated HPV tests. So most of us are, at least I'm using this COBAS HPV testing, especially for community screening. It's a validated test. And this Gene Expert HPV is again a point of care HPV test because you'll get the result in an hour's time. Whereas in COBAS HPV, it's a batch processing. So you can collect some 50, 60, 100 samples and give to the lab. They will analyze and give it. Lots and lots of Indian HPV tests are also coming into market. And some of these are getting validated. So once they are validated and approved, then we can start using those tests in our practice, because the advantage is once the Indian tests are being used, the cost would definitely come down. When we are using these tests, cost is the main factor for us to move towards completely for primary HPV testing. So this is a Gene Expert HPV machine. I think most of you must have seen. And this Gene Expert can be used for variety of tests, not for HPV. You can even for TB Gene Expert. Then you can use HIV, HBsAg. So for so many things, the only thing is the cartridges would change. This is COBA's HPV testing, which can be used for batch processing. So the reports, what you get, if we do Gene Expert, usually the report comes like this, whether it is HPV 16 positive, HPV 1845. This is one of the reports. So here we are seeing HPV 16 positive. Others are negative. So basically you will know 16, 18 or 45, which are very important for us. Even other high-risk HPV types in the Gene Expert machine, they have divided, again, further subdivided into P3, P4, P5. So remaining high-risk HPV types, they are subdivided into this P3, P4, P5. This report is not here. So here, very clearly, you know that this lady has got HPV 16 positivity. So once somebody is HPV 16 and 18 positive, you need to be on a high alert to evaluate that lady further. When it comes to COBA's HPV testing, usually you get the reports like target 1 is for other high risk, target 2 is for HPV 16, target 3 is for HPV 18. So here also you will know these are all partial genotyping. That means you not only know that they are HPV positive, you also know whether they are positive for 16, 18 or other high risk HPV types. So why I'm talking so much about HPV testing is, again, going back to the latest recommendations by WHO, for the general population of women, you can use screen and treat or screen, triage and treat. So for both the things, they are recommending HPV DNA as a primary screening test. Starting age is 30 years. And the advantage of HPV DNA testing is you can do it every 5 to 10 years. Instead of doing every 3 years, you can do every 5 to 10 years, especially in general population. So that's why in that guideline, they said twice in their lifetime, that is 35 and 45. So coming to women living with HIV or other immunocompromised states, you can start screening them at the age of 25 because they have a lower chance of clearing their infection. Here also they have recommended HPV DNA. So the only difference between here is you can here screen and treat, but here in HIV women, you should screen, and if they are positive, you triage them with colposcopy and then treat them. So there is nothing like a screen and treat directly in HIV positive women because the HPV infections are more commonly seen. HPV affection that is producing the changes also is more common compared to the general population. Here, of course, the screening interval for these women is between 3 and 5 years, but not 5 to 10 years. So these are the major changes which are there in the latest recommendation. So we need to be familiar with these things. And this is also our FOXY 23. It also has said the same thing. Of course, as I said, they're still using the word resource setting, good resource, low resource. So in good resource, preferred is primary HPV testing, acceptable is cytology. In the low resource setting, affordable is HPV test, where available, otherwise BIA. So probably I feel, we need to work more, move towards this preferred HPV testing, even though it appears to be costly at the point of time. But in the long run, when you do the number of tests and the sensitivity, going by the sensitivity, I think it stands first compared to the other things which I'm going to show here. So if you go by the accuracy of the screening test, the advantage of HPV is it's highly sensitive and it has got a very high negative predictive value. Of course, the specificity is low, but it has got a high negative predictive value. If you say somebody doesn't have HPV, the chance of she getting a pre-cancer and cancer are quite negligible. The sensitivity of the VIA and cytology are almost same. Of course, the specificity is more with the cytology. And with the cytology and VIA, there can be intra-observer and inter-observer variations. Here in HPV, it's done by the machine. The chances of errors are considered to be lesser compared to these other tests. So the frequency of screening, we all know, like the recommendation still in our country for general population is between 30 and 65. And of course, we do screening from the age of 25, if at all we do. Use cytology, not HPV testing. If you are using BIA once in 3 to 5 years, cytology once in 3 years, HPV as a primary test in general population once in 5 to 10 years, in immunocompromised 3 to 5 years. And some places still people are using co-testing. Co-testing also is once in 5 years. There is a debate whether we should do exclusively primary HPV or co-testing. Some are very comfortable doing co-testing, but even if you do primary HPV testing, it's equally effective. You need not always go for a co-testing. So if hysterectomy is done for any indications of CIN, then probably you need to do the walt smears. If it is done for AUBs and fibroids, and before hysterectomy you have ruled out all these CIN changes, there is no need to do the walt smears post-hysterectomy. So we need to be very careful in deciding for hysterectomies after exclusion of any of these changes, because we don't want women to come back with walt growths or vaginal growths. So that's why it's mandatory that we do screening for cervical cancer before we decide for hysterectomy for any other indications. So just one word about automated visual evaluation. It's a machine learning algorithm, because everywhere now we are talking about artificial intelligence and other things. So, but for this, it is not so simple as said. We need to have a good data bank of a lot of digital images. So we have to collect the digital the images, first store the images and train the machine to identify what is normal and what is abnormal. So that is what is the artificial intelligence algorithm is. So here this is the cervix, speculum. There are lots of mobile devices where we use and take the images and store the images, and those images are all converted and set into the cloud, and all those finally these cloud images are all being fed to the machine for machine learning. And then finally, this artificial intelligence algorithm is being used. So what they say is, instead of a clinician interpreting, the AI would interpret whether it is normal or abnormal. But I think these are mostly for healthcare workers, but not for the clinicians who are trained in doing all the screening tests and interpreting the things. And these are the two devices which are popular now. And I think all of you might have seen this EVA colposcope. So it's a mobile colposcopy device. You can actually do like a colposcopy, save your images, and you can give your own interpretation. Or you can, it also comes with this AI algorithm, and you can use that, and that will give you the report whether it is normal, abnormal, or suspicious. This is an Indian innovation, this mobile device, SmartScope. It's quite good. I use it. And here you get a good images. It's like a vaginal probe. You need to put it into the vagina, just about a few 4 centimeters minimum distance from the cervix. It should not touch the cervix. You can always adjust depending upon the length of the vagina. And the image is a small tablet. It has got all the program here. And same steps after cleaning the saline, then after acetic acid, after Lugol's iodine. So all those images you can capture. It will tell you what is to be done, kind of a thing. It's quite self-explanatory. It's not. It's very easy for anybody to practice. But once these images are done, saved, same you can use ask for the AI interpretation, or you can give your own interpretation. So like that also it can be done. So usually the report comes like this. You can save the images as many as you want, you can save, but whatever is needed only you can put in the report and give. So this is quite okay. I have a little experience. I sometimes use in the community screening, and all these images can be stored in your web portal, and you can access and interpret later also. So that is something about the screening test, and there are lots and lots of these devices are coming up, portable devices. Anyway, I'm not touching all those things. Some are being evaluated and some are on the various stages of evaluation. So what we need to know is, definitely we have to do screening. We should not lose the opportunity of screening any woman who comes to our clinic for whatever reason. We all know that, and we have been doing it. So be a VIA or HPV DNA, whatever. So these are the 3 algorithms which I'm going to show here. These are again our latest FOXY recommendations. So coming to screen and treat approach, especially in the general population. So primary screening, one of the recommendations, if you think you are in a low resource setting, you can use VIA. If you are in a good resource setting or your patient is affordable, you can go for a HPV DNA. If VIA is negative, you can call her back after 3 years. If it is positive, so we have seen how to interpret a positive lesion. So once you interpret the lesion, and if you think it's the lesion is suitable for ablative treatment without any biopsy, you can do it and then call them back after a year for a repeat VIA, whether the change has disappeared or not. Suppose if you think the lesion is not suitable for ablation, like the lesion is extending into the endocervical canal, or it is a very thick white, and you may be you are suspecting that it may be a high grade CIN, then the option is either you can do biopsy or you can do an excisional procedure if the facility is there at your place, or otherwise she has to be referred to a place where the facility is there. So the advantage of doing this excisional procedure is you can actually take the tissue for biopsy also. So instead of doing biopsy and again calling them back, the same procedure, the excisional procedure, both diagnostic as well as therapeutic. Suppose if it is suspicious for cancer, definitely you need to do a biopsy, and after that you have to stage and do the treatment. So that is with the VIA. Coming to HPV DNA, if you are doing a partial genotyping test like what I have shown, you already know whether it is 16, 18 or other high risk types positive. Suppose if you are doing the ordinary HPV testing and you don't know the genotype, so then the other option would be, which would come in the next slide. So what you do is if HPV DNA test is negative, same, you call them after 5 to 10 years. If it is positive, so what they have said is instead of doing colposcopy, everybody may not have a colposcopy facility or colposcopy training. So same VIA again, you can apply in a HPV positive, because HPV positive doesn't mean that they have a lesion. So you have to see where the lesion is. So for that, you have to apply acetic acid. And again, the same principles apply here. So what we need to understand is having HPV infection or HPV test positivity doesn't mean that they are going to have changes in the cervix. As I said, if it is in the transient phase, they don't have any changes. You will see absolutely normal colposcopy. Or even if you apply acetic acid, you may not see any changes. So then definitely you need to reassure them saying that the infection would clear. We would repeat the HPV DNA testing after a year. Like that, you can reassure them. But if you see estro-white lesion, again, you can triage the estro-white lesion based upon the thickness and other things and eligibility for the treatment. So this is the screen and treat approach in using VIA or HPV DNA. Suppose still many places I know we are doing cytology. So if you are doing a cytology, either conventional or a liquid based, if it is negative, you can call them after 3 years for repeat cytology. If it is positive, you have to see the grade. Ascus. If it is Ascus, then they say reflex HPV testing. If reflex HPV testing is negative, you can call them back after 1 to 3 years for a repeat co-testing. Suppose if it is Ascus and HPV positive, better is to take them for colposcopy. So now in the previous guidelines, even LSIL also, they were recommending reflex HPV testing. But now with LSIL or more than LSIL, that means HSIL or whatever it is, you need to do a colposcopy. So only Ascus reflex HPV testing, and based upon that, you will decide. Whereas LSIL or anything more than that, that is HSIL or ASC-H, you need to do for a colposcopy plus or minus biopsy. Then screen, triage, and treat approach, which we were discussing. So in screen, triage, and treat approach, suppose you are doing a primary high-risk HPV DNA testing, which now the WHO is recommending supposed to be done. If it is negative, same 5 to 10 years. If it is positive, you can do a genotyping. If you have already done a genotyping test, it's easier. You can follow this algorithm. Suppose you don't have a genotyping facility or the person cannot afford, then you can do colposcopy or VIA. or you can then do a reflex cytology. So earlier we were doing cytology and reflex HPV, but here you are doing a reflex cytology. So primary DNA, HPV DNA positive cytology is also abnormal, then you can consider doing a colposcopy. Suppose genotyping is, you have already done a genotyping, and if it is 16 and 18, definitely you need to go for a colposcopy, because we are seeing more and more abnormalities with 16 and 18 types. We don't want to miss. Whereas other high risk types, you can again do a cytology triage or VIA triage. If you can't do, if you have a facility, you can even go for a colposcopy. There is nothing against it, but you are not that much worried, at least for the time being, with other high risk types compared to 16 and 18. Probably after some time, we don't know whether these other high risk types incidence also would increase. We don't know right now. And we are also able to cover these 16, 18 types with our quadrivalent vaccine. So what is going to happen, other high-risk HPV types, probably we would be knowing in the few years, not immediately. But as today, the algorithm for high-risk HPV types is 16 and 18, one has to act faster. Whereas other high-risk HPV types, you can do a cytology triage or VIA triage instead of immediately subjecting them to colposcopy. So that is the screen, triage, and treat approach. So this is just the summary. Again, it is from our WHO guidelines. So visual inspection with acetic acid as the primary screening test, followed by treatment. That is in screen and treat. HPV DNA, self-collected, self or clinician collected, followed by treatment. Screen, triage, and treat approaches. So if you are using cytology as a primary screening test, you can decide about colposcopy triage, as I have shown in that flow chart. And if you are doing HPV DNA as a primary screening test, then go for a genotyping and then triage according to the type of HPV that is tested positive. If you are using HPV DNA as a screen and treat approach, you can use VIA just to identify whether there are any lesions on the cervix. If you are using high-risk HPV DNA as a primary screening test, you can also triage with colposcopy, followed by treatment, or you can do cytology triage. So here you are using HPV DNA as a primary screening test. So you can triage straight away with the colposcopy, you can triage with cytology and later colposcopy. So these are the 7 algorithms that are given in the latest WHO. So we can use any of these according to our setup. So if you are comfortable with screen and treat approaches, you can follow this. If you want to do screen, triage, and treat approaches, see what kind of a screening test you are doing. And accordingly, you can plan your triage options and treatment approaches. So just I have omitted the treatment because I did not touch much on colposcopy, because I think that maybe in your subsequent lectures, somebody would be talking about colposcopy and then the treatments, the ablative and the excisional treatment. So that's why I stopped here with the screening and what is to be done if somebody is screen positive. I just put a stop there. So thank you very much for your patient hearing, and I hope I've conveyed some message and information and clarity. You are in your CCC, confusion to clarity, I hope. So if you have any questions which I can answer, definitely I would be happy to answer those questions.
Ma'am, this was such an amazing lecture you took. I mean, this all things we are doing in routine practice, but this is, so volatile. I always, some patient comes and then I tend to open the guidelines and, well, acha, now what to do? So, but your lecture was so simplified and it, brushed up everything. And now I think I'll be better. I'll be able to better recollect and apply it in clinical settings.
Okay.
There is one question in question answer session, ma'am, from Dr. Rujita. How accurate is handheld colposcope compared to Karl Storch or Watch? Which company colposcope do you prefer?
No, actually, my preference is a digital colposcope. Okay. I mean, of course, if you have a luxury to have a binocular colposcope, fine, but I don't have a binocular colposcope. My experience is mostly with the digital colposcope, which I'm using is the Borg colposcope. So the advantage is the machine will be on the ground and it is quite stable. when you are using the handheld devices, of course, EVA colposcope also has a stand. So you can put it, but it needs a little bit of practice. So everything comes with practice. It's actually not the machine, it is the man who uses the machine. That is the most important thing. So once you get used to this EVA colposcope, then it also would be more or less comparable to the thing. So, but for teaching purposes and other things, I prefer a digital colposcope compared to the EVA colposcope.
Thank you so much, ma'am. I hope, Dr. Rujuta, your question has been answered. I think we are also using watch colposcope at our centers mostly. Ma'am, that was an excellent lecture in a very simplified
thank you.
manner, and
I would like
Just
that
want
that
I
laypersons to please chip in their.
comment on it.
Yeah.
yeah.
So can I
Thank
say
you.
something?
Thank you, Leela.
Thanks.
Because it's always, true to that CCC conference, you have cleared the confusion. Because we don't know, in many setups, we follow cytology, others follow HPV DNA. So there are so many classifications, so many flow charts. Which one to follow, which one not to follow, it's always a confusion. Then you made it simple. Depending upon our situation and circumstances, the facilities available, whether you are doing in a large scale, in a camp, or a rural setup, or a single, our own clinics with an urban population, it differs. Urban population usually prefer HPV DNA fast results, and then treat it fast. But in a mass screening, I think we have to go with your VIA, things like that. So you have clearly gave both charts, which one to follow. Thank you very much. I think it's for all the, if there are PGs, junior doctors, it's very easy to follow. Put these charts in the OP and then follow the management. Thank you.
Yes, ma'am. I've also clicked the screenshot for the application
Very
later
rightly,
on.
I think, Dr. Lakshmi, you have put it very rightly that she has made the thing so clear. Dr. Leela, it was an amazing lecture. Such a big subject, and you have covered and you have given such important messages to us. And you have very rightly told us that incidence varies from region to region. And here I want to share one thing, that though we call J&K, Kashmir is 300 kilometers away from Jammu. And Jammu list would be, the OT list would be full of prolapses and full of CA cervix or ovarian cancers. In Srinagar, hardly any CA cervix is to be seen. So those students would always say that, ma'am, hamare yahan to cancer cervix nahi milta hai. In our, setup, we have advanced cases. So circumcision, you said, might be, one of the reasons, because those areas, they have this, because this fashion, they have, every person has to undergo circumcision. And that might be, one of the reason for this. And then, a very important thing which you told us, that cytology is the lab method, morphology of exfoliated cells, and colposcopy is a clinical method. So colposcopy is complementary, not a substitute for cytology. We need to know that as, junior level and as undergraduate level also. And one of my favorite question to my postgraduates was that, what is this, transformation zone and squamocolumnar rejection, how this transformation zone is formed, and why we say that don't get your girl married at young age, why early intercourse hits these immature cells, because once you reach late 20s and late 30s, this transformation zone, the columnar cells, they become mature, and then it is difficult to differentiate whether they are the primary ones or the secondary ones. And that's how we say that early intercourse and early injury to the cervix is very, very crucial, because in our UG days, we used to mug up things early, sexual intercourse. We never knew how it happened.
Yes.
And, you have cleared the things so nicely. Thank you so much. Thank you.
Thank you. Yeah, thank you very much for the opportunity. I really enjoyed.
Thank you, Dr. Leah. It was an excellent lecture, madam. and you covered everything from VIA to
Thank you.
psychology and what to do when. It was an excellent lecture, ma'am. And the thing is, you just highlight the test. You're not going to, you are not take on the treatment part. So that was very good, ma'am. Because
Yeah.
sometimes that creates more confusion. If it is an actor, that is this, then that, do that, so it becomes very confusing. So you have made
Yes.
it very simple. Thank you, ma'am. Very much. Thank you.
Thank you very much. Thank you.
Why I wanted this topic, Dr. Leela, is that I recently only I had this opportunity to go to Sri Lanka at CIFOM conference, and where I was given a topic by the scientific team, the the Asian scenario for cervical cancer prevention. And when I went through the data, and it was, I mean, a really surprised and shocking for me that though we are very populous, probably that's the reason that we are very highly populous country in the world, and we are lacking the awareness among the
Yes.
clinicians, the gynecologists themselves, and we are not even taking 1% of the cases for prevention, and we need to catch up with the goal of WHO. So the awareness somehow comes to be very essential and critical for us. That is where we discussed that we are going to go through this screening, and I wanted the first thing which should be that we should focus on VIA, because not many people can afford, or many people can have colposcopes. Of course, that it is a necessity for any gynecologist, but they sometimes it is not possible. So VIA per se is very easy, very affordable, and very easily available per se. So you have literally covered each and every aspect of it, and that is so crucial for all the practicing OBGYNs. So I think what I had dreamed of, you have covered that part of
Thank
it.
you very much, madam.
And
Thank you.
Dr.
for
Leela, one more request I would like to put in, because
madam.
since you are involved in this field, many times when we do our public awareness camps, we want to do our pap smears, but we don't get the facility of getting it done free. And the government hospitals also do not give us this facility. So this should be a government program that collection we can do, but at least the reporting should be free. Because in private, many a times when you said low resource testing, I tell you, we have the low income people who really cannot afford these investigations. So until and unless we give them a free facility, we will not be able to eradicate this problem.
Yes, madam. I understand what you're saying. So that's why what
Shubha,
actually
I
I'm
am
doing
totally with
is
you. I'm totally with you. But one thing I want to stress upon is that the freebie thing is somehow put in our brain. We can afford to go for for clothes, for jewelry, but when it comes to our health, we are looking for freebies.
No, but Didi, when we really go
If
to the
we-
lower income strata, especially when we
no,
go for
even the
the
well-to-do,
camps,
I'm sorry,
huh?
even the well-to-do woman would not go for their pap smear
Yeah,
for
there
the
we
cost.
don't need to do it
For the
free.
cost thing,
But
if
in
you
the
give them
lower
free,
income
then they go.
strata, we need help. In the lower income strata, we do need help because they are not motivated, because for them, money for other things is more important. So if we give them help, probably we'll be able to help them out better.
I agree with Shubha, because camps means they expect a free service.
yes.
If you want to go in a large scale, mass screening, I think, but in our individual OPs, definitely, as Dr. Anju
Yes.
has said, yes, they spend so much on their beauty, this thing, parlors and all nowadays people.
Mobiles.
So, but for the mass
Mobiles.
screening,
They spend on their mobiles, but they will not spend on their health.
Yeah,
So
madam.
it is the last
agree.
priority in our country.
No, what actually I do is, as all of you have said, in hospital setup, everybody, whatever, only thing I counsel is, suppose if I have a HPV test and a PAP test available with me, but I tell them about both the tests, the effectiveness, the cost and everything, and they will choose because they have every right to choose. But at least they would choose one for the other. If not, they won't go away without doing a test. Those who can't afford HPV, at least they'll go for a pap smear. But when we go to community screening, especially in the rural areas, in camp setting, everybody expects a free testing, free medicines, and that is a very common thing. So the camps, what I've been doing in different parts, especially in the rural areas, I'm doing with the help of charities, madam. So I do this COBAS HPV testing. I do collection and send to a central lab. We can even send to Adayar Cancer Center, but they would charge. It's not a free test, but you will get it for a lower price compared to what you get it from a lab. So I do like that. So right now I'm able to get a test, single test HPV test done for 1,200 rupees. It sounds to be higher, but easier to collect. And the incidence of HPV, I mean, because it's a sensitive test, what happens is if the most you may see 8 or 10 women being positive, remaining 90 women would be free of this HPV infection. So you can reassure them. So we need to work with charities also. We have to identify the charities locally and first sensitize them, and they will definitely help you. You may not be able to do big numbers in a given time, but you can start slow and steady and covering the areas. That's what I've been doing, madam. Even for vaccination in the rural government schools, we are doing with the help of the charities. So the charity people will give money for vaccination. And when the parents come with the children for vaccination, we screen those mothers for HPV. I mean, I usually use HPV testing. In community, I find it very easy to do HPV rather than this cytology, because the same liquid medium can be used for both. But anyway, I'm happy with the primary HPV testing. But I'm doing with the help of the charities, madam. So that is the thing I can tell you. And in hospitals, wherever I work, in almost like every woman who comes to my clinic, we will encourage them to have the test, and majority would get it done, madam. They won't say no. It's the way you talk and counsel them.
Usually, I advise for the postnatal mothers, after 3 months, it's a routine. I just say it's a routine. They may ask, but it is for your uterine health. Because cancers, if we tell a newborn mother, postpartum ladies, it may not apply. So for your uterus health, routinely for all my postnatal patients, I do. Catch up. I mean, we have to grab the
Opportunistic.
opportunity.
Yeah.
And do the...
It's an opportunistic screening test.
Yes.
Yes, ma'am.
I think...
So should we conclude, ma'am? Thank you so much for the chairpersons.
One minute. So for everyone who's watching, can tell their friends and colleagues that we will be sharing the recording link. And we also have our own YouTube channel where we are going to put all the links. So you can revise your whole master class by going through this. And even if you have missed something or you want to retry something or recapitulate something, you will be able to see it. Yeah. Go ahead.
Yeah, okay. Yeah, as ma'am said, it's available on our YouTube channel. So thank you so much, ma'am.
Thank you.
Leela ma'am, our chairpersons, Lakshmi ma'am, Anjana ma'am, Sudha ma'am, again, Anju Soni ma'am, Shubha ma'am. So let's meet for the next meeting on the next Wednesday. Thank you so much, ma'am.
Thank you.
Thank you.
Bye. Bye.
Thank you for the invitation.
Thank you very much. Good night. Good night.
Thank you, ma'am. It was such a nice thing
Even
to
we can
attend this
Shruti.
lecture.
She does all this coordination, Shruti.
Thank you.
Thanks to her.
Thanks.
Thank you, Walter Bushner, for all the effort you people are taking.
Yes, ma'am. Thank you so much, ma'am. Thank you so much.